Thank you for joining today's Fireside Chat titled Factors That Matter in Vision Research. My name is Dr. Ruth Shoge, and I am an Associate Clinical Professor and Chief Diversity Officer at the University of California, Berkeley School of Optometry and Vision Science. I am currently sitting in my office at the university. I'm a Black woman with short, curly hair, kind of highlights on the tips, and I'm in my mid-40s. Today, I will be your moderator for the session, and we will explore key factors that impact eye health and vision research, including race, ethnicity, gender, and social determinants of health. And now I would like to introduce our panelists for this session. Dr. M. Roy Wilson is the President Emeritus at Wayne State University and Distinguished Professor at the Wayne State University School of Medicine. Thank you, Dr. Wilson, for joining us today.
Well, thank you, Ruth. Let me also just mention that I consider myself to be a Black man, although increasingly I identify as also being part Asian, and I look like I'm part Asian with long hair.
Thank you so much for providing your description there. So we're gonna jump into our discussion, which I think is very exciting and very timely, considering the very rapid changes we're experiencing in our country regarding race and ethnicity and the conversations around that. So Dr. Wilson, you recently chaired the Committee on the Use of Race and Ethnicity in Biomedical Research for the National Academies of Sciences, Engineering, and Medicine. What was the impetus to convene this committee, and what was your charge?
So not everyone is familiar with the National Academies. So let me start off by just mentioning that the National Academies, both all three, the medicine, engineering, and sciences, they are charged to answer some of the pressing questions of their discipline, usually by Congress and sometimes by private foundations. And every now and then, they'll have a topic that all three of them are interested in, and that's then called the National Academy of Science, Engineering, and Medicine. And this committee was comprised by all three of the national academies to look at the use of race and ethnicity in biomedical research. It's a topic that all three academies have been interested in. In fact, as we were starting up, another consensus committee had just concluded its work, and that one had to do with population descriptors in the age of genetics and genomics. Basically, since the mapping of the human genome and all the genomic research that's going on, how do we, since race is not a good proxy for genetic variability, what do we call these different population groups? What's most appropriate? So the charge of this particular consensus committee was pretty simple. It was to first look at how race and ethnicity was being used currently in biomedical research. And then secondly, to give some guidance on how it should be used in biomedical research, as well as some comments about how it should not be used in biomedical research. So that was a charge.
And it's interesting that you mentioned that these more recent research is finding that race and ethnicity are not appropriate or maybe not precise proxies for really understanding health disparities and health outcomes. So the committee's work resulted in the report, Rethinking Race and Ethnicity in Biomedical Research. Why are these findings specifically important to vision and eye health communities, particularly those in attendance of today's session?
Yeah, so the recommendations and conclusions of our committee was not specific for any one discipline, but was actually relevant for all of medicine. And the reason why it's relevant for vision health community is that we're a part of medicine, we're part of health. We all want good health for our population, and vision health is a very important part of that goal. And so to the extent that the committee took a lot of pains to make sure that all of its recommendations and conclusions were going to be relevant to whatever discipline you happen to be in medicine, it's relevant to the vision health community.
The eyes are not disconnected from the rest of the body, as we sometimes like to remind people. And so, it's one body, one health. And so that makes sense that we would be included in these conversations and increasingly having a seat at the table with these conversations. So kind of circling back to you mentioning, proxies for health, and you mentioned genetics. What would you say are some of the limitations and potential risks of continuing to use race and ethnicity as stand-ins for biological or genetic differences? And maybe not necessarily stand-ins, because I think some folks understand race and ethnicity as socialized terms and not biological terms. But even in our understanding of these terms as social-cultural terms, what are still some of the limitations and risks?
Well, race is a poor proxy for genetic variation. In fact, there's so much ambiguity between populations that we call races, and so much variation within race that two people of European descent can actually be more similar to someone from Asian descent than with each other. A good example is if you look at David Watson from the Watson and Crick Nobel laureate fame, and Craig Ventnor. They were the first two people to have their genome mapped. David Watson was initially the director of the National Genome Project before it was taken over by Francis Collins. But they were the first two people to have their genome mapped. Dr. Kim from Korea was the first Asian to have his genome mapped. There's more similarity between Dr. Watson and Dr. Kim and Dr. Ventnor and Dr. Kim than Dr. Watson and Dr. Ventnor, who are both people who everybody would consider to be white. And so that's an example of how race is really a poor proxy for genetic variation. The way it can get you in trouble is because it's a social variable and not a biological one. When it's used to make predictions about disease, for example, a very common one has happened to be, let's say, sickle cell anemia, sometimes being thought of as a Black disease. Well, it's not a Black disease. It just so happens that a lot of people from Africa get the disease because they are also living in areas that's endemic for malaria, and having sickle cell trait is protective for malaria. And so if you look at other regions of the world, particularly in Southeast Asia, you'll see high prevalence of sickle cell disease there also. And thinking of it as a race-based disease, one will miss a number of people who are not Black or from Africa who have the disease.
Often use that example as well when discussing this, with students, because it's a fairly easily accessible, particularly in the healthcare field, for people to understand sickle cell and the associations that are made. And we see some of those same associations with vision when we think of people who are more likely to be myopic, or people who are more likely to have primary open-angle glaucoma, and the risks of that thinking, but also missing some of the other factors that are associated with disease risk and outcomes. And so what are some of those other factors that we should consider, particularly if we're now understanding race and ethnicity as poor stand-ins or proxy? And what are maybe some of the undercurrents that continue to tie us to creating these associations with race and ethnicity?
Yeah, so I think the goal is to look for factors that are more causally related to the disease, right? Um, Race, for example, I use glaucoma as an example. You know, I've been as guilty as anyone in describing race as a risk factor for glaucoma, particularly those who are Black or African American. And it is a risk factor, but it's not causally related, right? So what are the factors that are more causally related? Well, in glaucoma, one can look, for example, at corneal thickness, central corneal thickness, or corneal hysteresis, both of which have been shown by the ocular hypertension treatment study to be very significant. In fact, central corneal thickness, if you controlled for central corneal thickness, the ratio effect in getting glaucoma in ocular hypertension treatment study was almost totally taken away. There was still some residual, but it was greatly reduced. And then subsequent research with corneal hysteresis, same thing, you know, low corneal hysteresis leads to increased chances of developing glaucoma. These are the types of things that we're going to be missing if we just focus just on race. And another example would be social determinants of health. The example I gave initially was just for glaucoma, but social determinants of health is likely to be at play no matter what the disease is, but there's a lot of interplay between social determinants of health and disease prevalence and incidence.
We've definitely learned more about social determinants of health lately. And just to kind of let our audience know who may not necessarily be familiar with social determinants of health, what they are. This typically includes socioeconomic status, education, employment, access to healthcare, usually through insurance plans and transportation and other kind of environmental factors. You have, you know, a safe place to be able to walk and play and work. And we're learning that these more directly influence or may have more of an influence on health disparities compared to race or ethnicity labels in healthcare.
Yeah. I'll give you an example, Ruth, if I could. I'm back to seeing patients now after 20 some years in administration, and I see glaucoma patients. About a month or so ago, and this was in just a half day of clinic, in 1 week, I saw 3 African American patients who had gone blind in one eye over the last couple of years since they were last seen in the clinic. And so I asked each of them, there was 3 of them, I asked each of them, why did they not come in earlier? Why did they wait 2 years before coming back to be seen? One of them told me that he didn't have transportation and nobody would bring him. Okay. Another one told me that his health insurance had changed and he didn't have insurance anymore, and so he was waiting to be able to get insurance again. Okay. And then the third one said that he ran out of his drops. He didn't realize how important it was to continue to get his drops. And so once he ran out, he just thought everything would be fine. And he just didn't continue to be treated. So just in that 1 week is 3 examples of social determinants of health dealing with transportation, with health insurance status, with educational level, that shows how profound an effect these other factors can have on outcomes related to health, and in this case, blindness.
And I think it's important for us to continue to have these conversations. And I've done a series at a conference really asking, is there a case for race in some of our patient encounters, because it tends to cloud our judgment and really miss the factors that are actually relevant to our patient cases. So thank you for providing those examples. So even though the research puts race and ethnicity into context as unreliable predictors of disease and health outcomes, do you think these factors still play a role in healthcare? If so, how?
Yeah, they do. Even if you control for socioeconomic status and other variables, there's usually still some residual effect that is present, in terms of racial disparities. And so we think that factor has to do with the fact that race has such a prominent role in today's society. It has a role in terms of, distribution of wealth, and in terms of how people are treated, and what kind of stress people are under. There's not just only bias and stereotyping, as you were alluding to, Ruth, but also just outright racism. And there's a concept called weathering that basically hypothesizes that just chronic stress over finances and other issues takes a toll on one's body, and ultimately leads to adverse health effects. And so there's some other factors that are going on besides social determinants of health, and some of the factors that we just mentioned, that is race related. And it has to do with how society, what kind of importance society places on race, and the fact that there still is racism in this country. And so you have, even though race is not a biological variable, it's a social variable, it has health consequences that are biological in nature.
That's biologically, absolutely. And it's becoming more challenging to speak frankly about these issues, about naming racism as a determinant, as a social determinant, really, in the context of healthcare, and how we need to, put race and ethnicity in its place when we're thinking about it, in health disparities, but also not be ignorant to the fact that it does play a role in the ways people show up to their doctors, and how they're subsequently treated when they show up to the doctors. So
Absolutely.
how can eye care providers integrate assessments of social and environmental determinants into patient evaluations to provide more personalized and effective care? And if we did that, what do you think the impact would be?
Yeah, I think there's more and more data that is coming out in terms of the importance of these factors in relation to health outcomes. Certainly, again, speaking in terms of glaucoma, there are a lot of recent studies, and by recent, talking about 2023 and 2024, a lot of recent studies that show vulnerability index, social vulnerability index, as being directly related to glaucoma outcomes, visual field, and OCT outcomes. We don't have quite as much data right now on environmental aspects of these risks. But we do know in many cancers, for example, that the environment makes a big difference. So it's not a stretch to think that environment could have an effect on other chronic diseases. And so I think one of the challenges is that we're not used to, and when we weren't taught in our training, to pay much attention to these other factors, the social determinants, social vulnerability, transportation, healthcare, insurance, these kinds of things. And I think that as a vision care community, that these are variables that we should be looking at and charting in our medical records.
Agreed. And with the more kind of ubiquitous use of EHR systems, they are building that into the systems now where you can ask these questions. We are currently using Epic and transitioned and to Epic recently. And so Epic does have social determinant of health factor questionnaires that you can use in the evaluation. And eye care providers should absolutely be asking these questions, because sometimes we end up being de facto primary care providers, because people will come to see us because if your vision starts to go or comes blurry, or vision is very precious to people, and so they'll come and see their eye doctor maybe before going to see their primary care doctor. And so collecting this information, and then as we gather this data, I think we'll be able to see really the breadth of how impactful these different social determinants. So the first step is actually gathering the information so we can really see what the impact is and how we can go addressing it, both at the community level within our practices, but really the biggest change will happen at the societal level, where through the change of policy and how we take care of a society and come to agreement on that somehow.
Yeah, no, I agree. And I also think that, all this big data analysis that is now going on, for example, the NIH All of Us program, where they're trying to get 1 million different people to share their data, which includes not only genetic material, but also healthcare, behavior styles, and even up to the point of wearables. You get all these different variables now, and these big data data sets that would be able to start looking at the effect of some of these behavioral changes and some of these lifestyle factors that we currently don't have a lot of information on right now.
And how do you think policies can be reformed to support the collection and utilization of data on social and environmental determinants in health research?
Well, I think the first thing is just a recognition that when we use the convenient terms of race and ethnicity to talk about health outcomes and disparities in health outcomes, that recognizing that that is a proxy for other variables that are more important and more causative, as we were talking about earlier. Recognizing that and incorporating that into our medical practices, I think that's the first step.
So Dr. Wilson, what do you think are the next steps for the vision and the eye health community from the information we discussed in this session for moving forward? What can we do as a collective to move forward with this information?
Well, as we discussed already, the vision health community is part of a broader ecosystem of medicine and health. There are a number of guidelines now. For example, JAMA has a guideline on the proper use of race and ethnicity in terms of their publications. I looked at those guidelines and looked at the top 3 ophthalmology journals to see to what extent we were complying with those guidelines. And I have to tell you that there were a lot of misuses of race and ethnicity in the top 3 ophthalmology journals. I can't talk about them in detail because it hasn't been published yet, although it's been submitted for publication. But there's a lot of improvement that the vision community can make in terms of properly using terms of race and ethnicity in its publications and in its presentations, medical presentations, and such things.
Yeah, I've been referencing that article as well, and just kind of to give folks an example of how race and ethnicity should be used in publications. It's really defining what you mean by Black, for example, or white or Asian, who is included in those categories, and what is the specific need for including race. It will help to provide context for the use of race. So we can really start to move away from just associations that are not true and doesn't allow us to get to the real nature of health disparities and also how to really solve the problem. So we're not just continuing to spin on the same hamster wheel that we have been spinning on to really make progress. So thank you for sharing those ahead of publication. I feel very privileged for being able to kind of see this ahead of time, and we look forward to that publication when it comes out. So we're gonna go to the Q&A box now and try to answer the questions. So what advice do you have for junior faculty who are starting their careers in academia that have dedicated their training and research thus far to I envision health equity in such unknown times for not only funding, but being able to say specific terms such as racism and segregation, many other terms that were on that list? Great question.
Yeah, great question, and certainly a big issue for junior faculty, but a issue for faculty at all ages and ranks. I'll tell you, for example, since I left the administration as president about a year and a half ago, I've written 2 grants related to glaucoma and social determinants of health. And neither one of them are even being reviewed after, really many hours and days and weeks of working on these grants. So I can feel the pain for junior faculty who are just starting and having the same kind of things happen to them. The way I look at it is this. I do not think this is a permanent situation. A lot of damage will be done over the next few years. There's no question about that, and we are going to go backwards. But I don't think it's a permanent situation, and it's not permanent because a lot of this just doesn't make any sense, really. We've got to get more strategic. We may have to make some changes in how we present some material, and some of the changes are appropriate changes. For example, we shouldn't be giving one group of people certain advantages over another group of people, just by the fact that of a racial category. And so there are some things that are okay to change. But I think, some of the, when it goes to the point of being actual racist and actually silly, like not allowing research on transgenic mice because it sounds a lot like transgender mice. I mean, that's really getting to the absurd. And I think the pendulum has swung way over in one direction. I think it's going to start going into the middle, and I don't know how long it's going to be. But my advice would be, try to weather it out, and in the meanwhile, make modifications as necessary to be more fundable for the short term.
Yeah, great advice. It's really just sticking in it for the long haul. I worked on a grant earlier this semester where I had to scrub every word related to DEI, including my own job description, just for any kind of hope of it getting funded, which I have very little, but it got done. So it's really, even through the tears, you're doing the work anyway. And unfortunately, that is the advice at this time. Next question, how do you connect with organizations or other researchers that are concerned about social determinants of health for the long haul? I have found many are shifting their focus to other research focuses now that research associated with these terms are losing funding focus for institutions. So I think we kind of touched upon that a little bit. And while I was very against changing terminology, I think short-term and long-term strategy is really what's going to get us through this moment in time. And if it is being creative about how and when we're using certain terms, then that's what we're going to have to do. And, not throw out the good with the bad, but create some modifications. I don't know if you have anything else to add to that, Dr. Wood.
Yeah, I do have something to add to that. I think that now is not time to go backwards and shrink our responsibilities. That's easier said than done, and I think it's particularly more difficult for junior faculty. So I think it's really incumbent on people like me. I don't have a lot to lose at this point in my career. But I think it's incumbent on people like me and others to really bear down and not only continue the work, but to have a recommitment to it in a way to keep things going in this area of research and scholarly activity for when the tide does change again, that we haven't lost, a whole generation of young investigators who have become disillusioned. There are many of us who can carry the water for a while and allow sanity to work back into the system.
I'm encouraged by folks who say we've been through this before and we can come out on the other side of this. Unfortunately, this is not a new playbook we're seeing.
Yeah, I think class is another. Class isn't used as much in the United States as in many other parts of the world. Particularly, I'm thinking about Britain, for example, India, some other places. But it is, still used, and it's a social determinant of health. It's a measure of socioeconomic status, and as we already talked about as in the conversation with Ruth and me. Social determinants of health, such as socioeconomic status, has a huge impact on health disparities and on health outcomes. And so class, I think, will also have an outcome that's probably similar to social economic status, although it is not studied as well as some of the other social determinants that are more common in the United States. The last one says, do you believe that race, ethnicity can moderate the effect of social determinants of health due to racism? Thus, racial and ethnic minorities may have additional additive effects compared to non-Hispanic white patients that experience the same social determinants of health. Okay, that's a complex question. I will say this, and I hope this answers the question. There's well, he's now a resident at UCLA, but he was a PhD student. His name is Ken Kitayama, who for his PhD thesis looked at socioeconomic status and race as in their effect on glaucoma surgical outcomes. And what he found was that race was a mediator for social economic status. And so there's an interaction between both race and socioeconomic status. Although a bit different from the question that you're asking, I think the bigger 1,000-foot view here is that there is an effect of both social determinants of health and something related to race, that's specifically related to race. And I think that something is one possibility is racism. And so if I interpret the question here appropriately, then I think there probably is additional additive effects of race on top of the social determinants of health. And I hope I answered the question.
Thank you, Dr. Wilson. Yeah, I don't think the conversation about race and ethnicity is going to go away anytime soon. But I hope that our conversations today expanded the thinking on how we should think about race and ethnicity and class, how we should think about social determinants of health, and what we really need to do to reduce health disparities, reduce uh, vision disparities, and create better health outcomes for everybody in our communities. So I really appreciate the conversation that we've been able to have. Thank you so much um, for just giving us some insight and sharing ahead of time some of the publication that we very much look forward to. So thank you, Dr. Wilson, and thank you to all of you who joined us today.